Dear colleagues, welcome to the second annual OncoAlert Colloquium brought to you by the OncoAlert Network and our amazing partners at ESO, the European School of Oncology, eCancer, EONS, the European Oncology Nursing Society, MASC, the Association of Supportive Care, SIOG, the Society for Geriatric Oncology, IGCS, the International Gynecologic Cancer Society, and SWOG Cancer Research Network. My name is Gilbert Morgan. I'm a clinical oncologist, displaced Texan practicing in southern Sweden, and director of the OncoAlert Network. The colloquium, which you're about to see, is an end-of-the-year review taking place daily from January 10 to January 16, bringing you the most impacting findings in oncology of 2021, divided by tumor type, and delivered by an amazing hand-picked faculty of world-renowned oncologists, oncology nurses, and of course, amazing patient advocates. This, as with every OncoAlert initiative, has been realized with absolutely no financial support. All the presentations which you are about to see this week will be free, always available, and will require no registration, and we will not be tracking your data. The amazing faculty that makes up our network believes that through working together and making education available to all is the only way to move forward for the development of our field and for the better treatment of our patients. We welcome you to day one of the colloquium, where we will be seeing presentations on genitourinary cancers and the SIOG sessions on geriatric oncology. Our presenters are Dr. Toni Choueiri, Division Chief of GU Oncology at Dana-Farber, USA, presenting on kidney cancer, Dr. Andrea Apolo, Chief of Bladder Cancer Section at the National Cancer Institute, USA, presenting on bladder cancer, Dr. Neeraj Agarwal, Director of GU Oncology at the Huntsman Cancer Institute, USA, presenting on prostate cancer, Dr. Piet Ost, radiation oncologist from the Iridium network in Belgium, presenting on radiation therapy in bladder, testis, and kidney cancer. Dr. McBride, Associate Attending Chief at Memorial Sloan Kettering, USA, presenting on prostate cancer radiation therapy. Our partners at KidneyCan USA will be giving you a patient advocate perspective. I will then have the pleasure to give you a brief update of the network. My name is Gilbert Morgan, clinical oncologist from Skåne University Hospital, Sweden, in Lund. And ending with the SIOG sessions, where we will have the pleasure to welcome Dr. Ravindran Kanesvaran, SIOG President from Singapore, and Dr. Nicolo Battisti, SIOG President-elect from the UK, both giving us updates on geriatric oncology. On behalf of OncoAlert, our partners, and our faculty, it is an immense honor to be able to present this colloquium for you, our colleague. So without further ado, day one of the OncoAlert Colloquium, and to get us started, the heart and soul of our network, Dr. Toni Choueiri.
Hi, everyone. I'm Toni Choueiri from the Dana-Farber Cancer Institute. Pleased to be part of the OncoAlert Colloquium 2021. Going to review at least what I think the most salient papers and research from 2021. Thank you, Gil and OncoAlert, for the invitation. These are my disclosures. And overall, this is what I think 2021 during COVID already brought in to renal cell cancer. We're going to discuss metastatic RCC, two major trials published in the New England Journal of Medicine. There is a trial also in non-clear cell RCC dealing with papillary renal cell cancer. Finally, after years and decades of waiting, we have a new standard in the adjuvant setting in RCC. I'm going to touch base on novel targets. And finally, just a slide or two on some of the translational research in RCC. It was the year of single cell sequencing. Starting first with metastatic first-line clear cell renal cell cancer, two papers published back-to-back in February and March 2021, dealing with combination therapy. Both combinations showed superiority versus sunitinib, one with nivolumab and cabozantinib, the PD-1 inhibitor and the oral TKI, and the second one with pembrolizumab and lymphatinib. This is the first study, Checkmate 9ER. This was the schema of 9ER, again, metastatic untreated clear cell renal cell cancer of all IMDC risk groups, randomized to nivolumab, cabozantinib at the 40 milligram daily dose of cabozantinib versus sunitinib at the standard dose, with the primary endpoint being progression-free survival. The progression-free survival with the combination of nivolumab and cabozantinib was doubled. It went from 8.3 to 16.6 months, corresponding to almost 50% decrease in the risk of progression or death. This trial was updated with more follow-up from 18 to 23.5 median follow-up. Response rate still double versus sunitinib, and progression-free survival stayed the same with a hazard ratio of 0.5. The hazard ratio for OS was a bit more towards 1, but continued to be quite significant at 0.66. The second study is the CLEAR study. That was a 3-arm study with control arm sunitinib, but then 2 lenvatinib-based combination that were at that time experimental. The combination of lenvatinib and everolimus, this is in the middle. This is a non-PD-1 based combination that is approved post TKI failure, but not in the front line, and the combination of lenvatinib and pembrolizumab. Primary endpoint, progression-free survival. And these are the highlights. The combination of lenvatinib and pembrolizumab resulted in a median PFS close to 2 years, beating sunitinib hands down. Sunitinib PFS was 9.2 months. Even the lenvatinib plus everolimus PFS was better than sunitinib. Then what we see is also the overall survival benefit with the PD-1 based combo with lenvatinib and pembrolizumab. This was not achieved with lenvatinib and everolimus, and this is why we have the len-pembro arm, the len-pembro combination approved, but not the len-everolimus. Also, if we look at response rate, they were quite high, and the highest to date at 71% with lenvatinib and pembrolizumab was an impressive complete response of 16%. Another combination approved by the FDA, in addition to cabozantinib, nivolumab, here lenvatinib and pembrolizumab. Now we did an overall survival update from 26.6 to 33.7 months. The hazard ratio stayed significant, again, became closer to 1, but stayed significant with a hazard ratio of 0.72. We updated that, in the fall of 2021 during the KCRS meeting. Non-clear cell RCC, we witnessed finally the PAPMET study. This is a study presented by Dr. Paul and published in the Lancet in unselected first-line metastatic papillary renal cell cancer, the second most common type of renal cell cancer. This was a study of 4-arm control arm against sunitinib, but cabozantinib, which is a VEGF TKI, but also MET inhibitor among other kinases that are targeted by cabozantinib, versus crizotinib or savolitinib, both crizotinib and savolitinib not targeting VEGF receptors. And initially, after an interim analysis, both crizotinib and savolitinib arm were stopped early because of absence of efficacy, but then sunitinib and cabozantinib arm continued. And at the end, the study showed after a cutoff in October 2020, cabozantinib to be superior to sunitinib. The primary endpoint was PFS, 9 versus 5.6 months, similar to response, 23 versus 4%, suggesting a new standard in unselected metastatic frontline papillary renal cell cancer. What about adjuvant? Finally, after a long wait, this was the first immunotherapy trial negative in 1992. Here from the German group with interferon, presented at ASCO 1992, and then at ASCO 2021 and published a bit later in 2021. Pembrolizumab is a potential new standard in this disease, and this was based on Keynote 564. So this study is in patients with high risk or intermediate high. So these are patients that have T2 grade 4 or sarcomatoid, T3 or T4 or N plus or M1 NED. They have metastatic disease outside the kidney, that was resected within a year of the nephrectomy. These patients were randomized to a year of pembrolizumab or placebo. the primary endpoint, disease-free survival per investigator assessment. And after only 24 months of follow-up, the arm with pembrolizumab showed a significant disease-free survival over a placebo with a hazard ratio of 0.68. And if you look at the 12 months and the 24 months, there's around 9% absolute difference in disease-free survival. We presented also at AUA some subgroup analysis. As you can see, all the hazard ratio here are less than 1, suggesting a benefit from pembrolizumab over placebo. And during the 2021 ESMO, also we presented quality of life. But before that, I want to show you an interim overall survival result. This is didn't cross the pre-specified p-value boundaries for statistical significance, only a bit over 50 events, actually 51 events out of 200 overall survival event for final analysis. But the results are encouraging. After a year, 15 months, the curves start to separate, has a ratio 0.543% difference, absolute difference in survival favoring pembrolizumab. Again, not statistically significant. So this continues this study result to mature. But I want to show you at ESMO 2021, we presented extensive quality of life data. This is the QLQ-C30, the physical functioning. This is the mean change, despite that pembrolizumab arm in green is lower than placebo. The 95 confidence interval do cross, and there was no statistical or clinical relevance suggesting pembrolizumab decreases the quality of life versus placebo. Novel targets here, HIF2, you probably heard about this transcription factor. And now we do have a drug, and we do have 2 papers actually published, one in April and one in November 2021. The first paper, the first one I'm gonna say, discuss is VHL, actually. VHL syndrome overall, and the second one is the HIF2 inhibitor in a population of metastatic clear cell renal cell cancer that was previously treated, and this was published in Nature Medicine. So just to give you a big view here, in both VHL syndrome and clear cell RCC, the VHL protein, if you want, is deficient, is pathogenic. Normally, what does VHL does act as a ubiquitin, E3 ubiquitin ligase, and lead to ubiquitination of the alpha subunit of the hypoxia-inducible factor HIF in an oxygen-dependent fashion, which result in the proteolysis of HIF. But when you have a pathogenic VHL variant, like VHL syndrome, a germline VHL, pathogenic VHL, or in clear cell renal cell cancer, which is defined in large part by a VHL mutation or alteration in general, then this VHL, this pathogenic VHL variant reduces the VHL protein activity, which result in the absence of HIF degradation. So HIF is stabilized, and there's a subsequent constitutive activation of HIF-mediated transcriptional pathways, leading to all sorts of oncogenic programs. Now, belzutifan, known also as PT2977 or MK6482, is a second-generation small molecule against this transcription factor HIF2 inhibitor that was really thought to be quite hard to target in the past. And this is the paper that published by Dr. Jonas and the group at the National Cancer Institute with Dr. Srinivasan and Linehan here. On the left, this is a nice figure here to show you before the time 0 how all these renal lesion, this is a renal associated VHL, were increasing a bit, and at time 0 when belzutifan was started, you can see stabilization or decrease. Also at the bottom left, you can see outside renal cell cancer lesions that did shrink, This is a cerebellar hemangioblastoma at baseline in week 24. The graph on the right is even more telling. These are the patient before the start at time 0 at belzutifan, how many had procedure, ablation of kidney tumors, partial nephrectomy, etc. And you can look, despite the short follow-up, very few had any procedure after. But this population was in VHL syndrome that did not have metastatic disease and were not previously treated. The overall response rate was close to 50%. Now, a different population of patients, this is metastatic clear cell RCC. Here, there's a somatic, mutation in the VHL gene. This was a 55-patient study with 3 median prior line of therapy in metastatic disease, including 2/3 who had at least 1 PD-1 inhibitor and 1 VEGF TKI. Response rate 25%, progression-free survival 14.5 months, and responses seen across IMDC risk group here. The tumor shrinkage rate overall was 64%. You can see also on your right here, there's a decrease of erythropoietin, which is, if you want, a pharmacodynamic marker downstream of HIV, was seen at all those levels, but not much beyond 120 milligrams once a day. And that's the dose of belzutifan here. Now, since this is a new drug, wanted to show you a bit some of the toxicity. This is different than VEGF or IO toxicities in renal cell cancer. Anemia is seen because of decrease in EPO, and this is from the renal cell cancer study, up to 50%, knowing that mostly are grade 1, 2, but there is around 26% in grade 3. That's an on-target toxicity due to a decrease in EPO, and really dose reduction, putting patient on erythropoietin, transfusion, take care of it. Very few patients, small percentage of patients discontinued because of treatment-related adverse event. Now, another side effects of HIF2 inhibitor to be aware of, this is again from the metastatic renal cell cancer trial, is actually hypoxia. And in the study here, it was 15% grade 3. We did not see any cardiac or pulmonary complication here. What's the pathophysiology here? Overall, the mechanism is not known with certainty. HIF2 in itself has an important role in the pulmonary vasculature and the carotid body physiology, such as blocking HIF2 might exacerbate VQ ventilation perfusion mismatch and the sensitivity to hypoxia. This is here a very nice paper from Sir Peter Ratcliffe, who won jointly with Greg Semenza and Bill Kalin from our institution at the Farber Nobel Prize in 2019. This is a very elegant paper that showed a rapid effect of the HIF2 inhibitor PT2385 on hypoxic ventilatory control. Now, this effect should not interfere much with normal respiration in patient under most conditions, but in those patients with chronic pulmonary disease, a lot of lung metastases, patient COPD, patient with pleural effusion, PEs, patient living at high altitude, who were relying on enhanced sensitivity to hypoxia to maintain adequate ventilation. These may be the patient that may get into trouble. So we need to watch for hemoglobin and pulse ox on patient on belzutifan, the HIF2 inhibitor. Now, if you go back to actually the VHL paper here, there was very few, maybe one case of hypoxia, because these were younger patients, non-metastatic disease, usually healthier overall, but we saw it more in metastatic, heavily pretreated patients. And finally, it could not finish without, a bit of translational science. This is the translational corner here. 2021 was the single cell RNA TCR-seq in clear cell RCC, with not 1, not 2, but 5 papers published between Cancer Cell and Cell papers, two papers from our group at Harvard, Dana-Farber, one paper from actually Sloan Kettering, one paper from the Crick, and one paper from Columbia here. And, many advantages here with single cell over bulk sequencing here. If you look at all those papers, using this powerful technology, the investigator were able to identify key tumor microenvironment population across disease stage and pre and post therapies, including immune checkpoint inhibitor. They identified candidate cell-cell interaction, between the T cell, the macrophages, and some immune dysfunction circuit, as well as some tumor-specific macrophage subpopulation and new potential targets here. This is an example how this technology is powerful, that can delineate tumor from other non-tumoral component here. This is just one example. This is the paper from our group from David Braun, Kathy Wu, Eli Van Ellen, and other. This is an example here where Dr. Braun and colleague took a look at the tumor microenvironment in early stage, normal, early stage, locally advanced and metastatic disease, and notice this T cell exhaustion that happened, not surprisingly, from early stage to advanced disease, and how these pro-inflammatory M1-like macrophage become M2-like macrophages. And moreover, Dr. Braun and colleague identified if you want, an immune inhibitory circuit between the T cell and the macrophages, and came up with a signature, a CD8 T cell M2-like macrophage signature, that is associated with worse prognosis and present more in metastatic disease. This could not have been done with bulk sequencing. So finally, I want to thank the OncoAlert team. At least as of late November, over 20,000 followers. Thank Gil Morgan for his vision, bringing us all together, and this movement, taking off during this pandemic. Hope you stay safe and healthy, and hopefully we'll see each other again, perhaps at some point. Thank you for your attention.
Thank you to Dr. Gil Morgan for the invitation to be part of the OncoAlert Colloquium. My name is Andrea Apolo, and I am a medical oncologist at the National Cancer Institute in Bethesda, Maryland. Today, I will discuss the biggest news of 2021 in bladder cancer, including key trials, practice-changing findings, and FDA approvals. The objectives for this talk will include to review the current standard of care treatment of urothelial carcinoma. We will discuss FDA label changes in advanced and muscle-invasive urothelial carcinoma, and review first-line chemotherapy studies of erdafitinib and enfortumab vedotin and sacituzumab govitecan, and adjuvant studies of nivolumab and neoadjuvant study of chemotherapy for muscle-invasive bladder cancer. This schema summarizes the current management of bladder cancer patients based on their stage: non-muscle invasive bladder cancer, muscle invasive bladder cancer, and metastatic disease. Today, I will focus on therapy for metastatic disease in the first, second line and beyond setting, and in muscle invasive bladder cancer. All of these changes that have occurred in 2021. So we will start with first-line chemotherapy with checkpoint inhibition combination studies in metastatic bladder cancer. There are several large phase 3 studies asking the question of the activity of checkpoint inhibition alone or in combination with chemotherapy versus standard of care chemotherapy for patients with metastatic urothelial carcinoma. I'll start with the INVIGOR-130 study, which was first reported at ESMO 2019. This study randomized 1,200 patients to 3 arms: atezolizumab alone, atezolizumab plus chemotherapy and placebo, or standard of care platinum-based chemotherapy. In all of these studies, both cisplatin eligible and ineligible patients were enrolled. And the primary analysis demonstrated a PFS benefit with atezolizumab plus chemotherapy versus placebo plus chemotherapy. And interim overall survival data were encouraging but immature. with the mature data planned for presentation for later this year, 2022. Looking at the monotherapy atezolizumab arm versus the standard chemotherapy arm, the chemo group appears to be doing better initially, but the atezolizumab arm crosses over at around 10 months. The overall survival data could not be formally tested, but favorable efficacy was seen in the PD-L1 high patients who received atezolizumab. And based on this data, the accelerated approval of atezolizumab for this indication will continue. An FDA ODAC meeting held in April 2021 voted 10-1 in favor of keeping this indication. The next study I want to discuss is the Danube study. This study randomized 1,000 patients to 3 arms: durvalumab versus durvalumab plus tremelimumab versus standard of care chemotherapy. There were 2 co-primary endpoints. The first one was overall survival in the monotherapy durvalumab versus chemotherapy patients that are PD-L1 high. So the study reported an overall survival of 14 months for the monotherapy durvalumab arm versus 12 months for the chemotherapy arm, with a hazard ratio of 0.89 in the PD-L1 high population. Again, we see that the chemo-treated patients are doing better initially in the first 9 months, and then durvalumab crossing over at this point. The second co-primary endpoint was overall survival in durvalumab plus tremelimumab versus chemotherapy. The study reported an overall survival for the combination of durva and tremi of 15 months versus 12 months for the chemotherapy arm, with a hazard ratio of 0.85. Again, we see the chemotherapy treated patients doing better initially and then crossing over at around 8 months. The Danube study unfortunately did not meet either of the co-primary endpoints for survival. And based on the outcomes of the INVIGOR-130 and the Danube study, in February 2021, AstraZeneca voluntarily withdrew durvalumab, and in March 2021, Genentech withdrew atezolizumab's second-line indication in metastatic bladder cancer. These agents are active in metastatic disease. However, they failed to show the predefined superiority to standard chemotherapy in this setting. So we have data available now from KEYNOTE-361. This study randomized first-line metastatic urothelial carcinoma patients to receive chemotherapy plus pembrolizumab versus chemotherapy versus monotherapy pembrolizumab. The overall survival for the combination of pembrolizumab plus chemotherapy versus chemo was 17 months versus 14 months, with a hazard ratio of 0.86. The study did not reach its predefined statistical benefit for PFS or overall survival. Looking at the monotherapy pembrolizumab arm, the overall survival was 15 months versus 14 months, with a hazard ratio of 0.92. Again, similar to what we saw with monotherapy atezolizumab and durvalumab with and without tremelimumab, with the chemotherapy group appears to be doing better initially, but the immunotherapy arm crosses over here at around 12 months. So in April 2021, FDA had held an ODAC meeting to discuss the first-line accelerated approval of pembrolizumab in metastatic urothelial carcinoma patients that are cisplatin ineligible and PD-L1 high. And the ODAC voted 5-3 in favor of keeping pembrolizumab's indication in the first-line setting. However, in August 2021, the FDA granted full approval to pembrolizumab, but only for patients that are platinum ineligible, and simultaneously removed the first-line indication for patients that are cisplatin ineligible that are PD-L1 high in the first-line setting for metastatic bladder cancer patients. So now we have 2 large trials that did not meet their primary endpoint, 1 study with immature overall survival data, and 2 studies that have completed accrual and we're awaiting data. Next, I'll discuss second and third line therapy for metastatic bladder cancer. We'll start with erdafitinib, which is a pan-FGFR3 tyrosine kinase inhibitor that received FDA accelerated approval in April 2019 for platinum refractory metastatic urothelial carcinoma patients harboring FGFR3 genetic alterations. This was based on a single-arm phase 2 study of 99 patients showing a 40% overall response rate. Currently, the Thor study is ongoing. This is a randomized phase 3 study of erdafitinib versus second-line chemotherapy with vinflunine or docetaxel versus pembrolizumab, depending on the prior therapy. Moving on to enfortumab vedotin, which is an antibody-drug conjugate targeting Nectin-4. This agent received accelerated FDA approval in December 2019 for metastatic bladder cancer patients that are platinum and checkpoint inhibitor refractory. At GU ASCO 2021, the results of the randomized phase 3 study of EV301, which randomized patients to EV versus second-line chemotherapy, were presented. The primary endpoint was overall survival. The study reported an overall survival benefit for enfortumab vedotin versus second-line standard of care chemotherapy with a median overall survival of 13 months for enfortumab vedotin versus 9 months for standard of care chemotherapy with a hazard ratio of 0.7. In the same meeting, the EV201 cohort 2 study was reported. This is a phase 2 study testing EV post-checkpoint inhibitor in cisplatin ineligible patients who had not received chemotherapy. The study reported an overall response rate of 52% in this population with a complete response of 20%. And based on these two studies, in July 2021, FDA granted full approval of enfortumab vedotin for both platinum and checkpoint inhibitor refractory patients who are receiving treatment in the third-line setting, or metastatic urothelial cancer patients that received checkpoint inhibition and are cisplatin ineligible. So the combination of enfortumab vedotin plus pembro was reported in the first-line setting for cisplatin ineligible metastatic urothelial carcinoma patients and showed an impressive overall response rate of 73%. And based on this data, the EV302 study was developed. Now, this is for the first-line treatment of patients with metastatic urothelial carcinoma. The study currently only has 2 arms. It's EV plus pembro versus standard chemotherapy. So moving on to another antibody-drug conjugate, this is sacituzumab govitecan, directed against TROP2 with SN38 payload. At ESMO 2020, we saw the results of the TROPHY-U01 cohort in 113 patients, showing an overall response rate of 23%. And based on this data, in April 2021, sacituzumab govitecan received accelerated approval by the FDA for patients post-platinum and post-checkpoint inhibition. The phase 3 confirmatory trial in metastatic urothelial carcinoma patients, TROPIC-04, is underway. So now we move on to muscle-invasive bladder cancer, and we'll start off discussing adjuvant therapy. There are 3 large phase 3 studies that have assessed monotherapy checkpoint inhibition post-radical cystectomy in patients high-risk muscle-invasive bladder cancer. We'll start off with the INVIGOR-010 study. This study randomized patients to receive monotherapy atezolizumab versus observation post-radical surgery and did not meet its predefined primary endpoint of improved disease-free survival. However, this year, the ctDNA exploratory analysis of the study was published. It showed that patients who are ctDNA positive had a worse disease-free survival and overall survival, and had a better disease-free survival and overall survival when treated with atezolizumab versus observation. The results of moving on to the Checkmate 274 study, the results of this study were reported at GU ASCO 2021 and subsequently published in the New England Journal of Medicine. The study reported an improved disease-free survival of 10.9 months versus 21 months, with a hazard ratio of 0.7 favoring adjuvant nivolumab in the intent to treat population, and a hazard ratio of 0.58 in the PD-L1 high population. And based on this data, in August 2021, the FDA approved nivolumab for the adjuvant treatment of patients with urothelial carcinoma who are at high risk of recurrence after undergoing radical resection. So now we have one negative and one positive adjuvant trial in patients with high-risk muscle-invasive bladder cancer, and we're awaiting the data of the Ambassador trial. The Ambassador study randomized 700 patients to receive adjuvant pembrolizumab versus observation. The study has now completed accrual, and we await the mature results. Lastly, I will discuss neoadjuvant therapy for muscle-invasive bladder cancer. The standard of care treatment for muscle-invasive bladder cancer is neoadjuvant chemotherapy with either gemcitabine and cisplatin or dose-dense MVAC. And this data is extrapolated from the first-line treatment of metastatic urothelial carcinoma. At ESMO 2021, the final results of the VESPER study were presented. This is a perioperative study of neoadjuvant or adjuvant chemotherapy in 500 patients that randomized dose-dense MVAC to gemcitabine and cisplatin. The majority of the patients, 88%, received neoadjuvant chemotherapy and were randomized to receive either 4 cycles of GC versus 6 cycles of dose-dense MVAC. The study did not meet the primary endpoint of progression-free survival at 3 years for one regimen in all patients in the intent to treat population. However, in the neoadjuvant group, the PFS at 3 years was higher for the dose-dense MVAC arm, 66 versus 56, with a hazard ratio of 0.7. The pathologic complete response rate was 42% for dose-dense MVAC versus 36% for gemcitabine and cisplatin. Based on this data, dose-dense MVAC should be discussed as a chemotherapy option for patients with muscle-invasive bladder cancer. So currently, there are several phase 3 randomized studies testing checkpoint inhibition in combination with chemotherapy versus chemotherapy that are enrolling patients with muscle-invasive bladder cancer. So in summary, for 2021, many studies have reported results, and there have been several changes to the management of metastatic bladder cancer patients and muscle-invasive urothelial carcinoma. So we'll start with the summary with first-line therapy for patients with metastatic urothelial carcinoma. The treatment is still platinum-based combination chemotherapy. This is with gemcitabine cisplatin, dose-dense MVAC, or gemcitabine and carboplatin. And atezolizumab is still an option for the first-line treatment of cisplatin-ineligible PD-L1 high patients. Pembrolizumab is approved for the first-line treatment of patients who are not platinum eligible, regardless of PD-L1 status. And we await the results of 3 large randomized phase 3 trials in the first-line setting, including the Checkmate 901 study, which randomizes nivo and ipi versus nivo plus chemo, the NILE study, which randomizes durvalumab plus durvalumab, and chemo, and the EV302 study, which randomizes enfortumab vedotin plus pembro versus chemotherapy. If any of these studies are positive, these would change the standard of care in metastatic bladder cancer. So moving on to second and third line therapy, and also I'll start off with maintenance. Avelumab therapy is approved for the maintenance treatment of patients who respond to platinum-based chemotherapy. Pembrolizumab, avelumab, or nivolumab are second-line therapy options post-platinum progression, and enfortumab vedotin is now approved for patients post-checkpoint inhibitor who are cisplatin ineligible, and as a third-line treatment post-platinum and checkpoint inhibition. Erdafitinib is a treatment option for metastatic patients that harbor FGFR3 alterations. And saxatuzumab govitecan is another antibody drug conjugate that can be offered as a third or fourth line option for metastatic bladder cancer patients. So moving on to patients with muscle invasive bladder cancer, Nivolumab may be offered to patients post-radical cystectomy or nephrectomy who, despite neoadjuvant chemotherapy or who are not eligible for neoadjuvant chemotherapy, have persistent high-grade muscle-invasive urothelial carcinoma. And for the neoadjuvant treatment of patients with muscle-invasive bladder cancer, Dosins and Vac times 6 cycles or gemcitabine and cisplatin times 4 cycles are treatment options for cisplatin-eligible patients prior to radical cystectomy. I didn't have a chance to talk about the neoadjuvant monotherapy checkpoint inhibitor trials that have been reported. Both the checkpoint inhibitor alone or checkpoint inhibitor plus combination CTLA-4 or chemotherapy have demonstrated activity in patients with muscle-invasive bladder cancer. And several large phase 3 trials are ongoing testing these combinations in patients with muscle-invasive bladder cancer. So overall, lots of exciting updates for the year of 2021. And we look forward to many more data updates this year for 2022. Thank you so much for your attention. I wish you and your family a happy and healthy 2022. Thank you.
Hello, my name is Dr. Neeraj Agarwal. I'm a professor of medicine and Senior Director of Clinical Research Innovation and Director of Genitourinary Oncology Program at the Huntsman Cancer Institute, University of Utah in Salt Lake City in the United States. I thank the organizing committee for inviting me to present the advancements in the treatment of prostate cancer, which occurred in 2021. These are my conflict of interest, which include all consultancy, honorarium, and the research funding given to me and my institution over my entire career. These are the developments that I will be discussing today. I'll start with the results from the STAMPEDE trial in the context of high-risk non-metastatic prostate cancer, followed by discussion of the PEACE-1 trial in patients with metastatic castration-sensitive prostate cancer, and concluding with the VISION trial in metastatic castrate-resistant prostate cancer. So let's start by discussing the results of the STAMPEDE trial in the context of high-risk non-metastatic prostate cancer. The results were presented by Dr. Gerhard et al. From the Royal Marsden Hospital in England at the ESMO 2021 meeting. The standard of care for men with high-risk non-metastatic prostate cancer is radiation therapy plus 3 years of androgen deprivation therapy. However, post-treatment failure rates remain high, and consequently, this is a population with high unmet need. In this trial, standard of care was radiation therapy plus 3 years of androgen deprivation therapy or ADT. A total of 1,974 patients were randomized to standard of care versus standard of care plus 2 years of abiraterone and prednisolone from 2012 to 2014. After that, in the year 2014 to 2016, enzalutamide was added to the abiraterone arm. Primary endpoint was metastasis-free survival. Eligible patients, as we can see here, had non-metastatic disease. These were newly diagnosed patients who were required to have lymphadenopathy or any 2 out of 3 high-risk criteria, which included a PSA level of 40 nanogram per mil or more, Gleason score of 8 or higher, or T3 or higher disease by MRI. I want to emphasize on MRI and not by digital rectal examination. This study also allowed patients who relapsed after definitive therapy. However, these were small number of patients, as we'll see down the line. So these data mostly apply to newly diagnosed patients who had either of these features. So either they had node positive disease or 2 of these high-risk features, 3 high-risk features. Patient characteristics were well balanced across arms. The median age was 68 years. Median PSA was 34 nanogram per mil. and 39% patients had node-positive disease, and only 3% patients had recurrent or biochemically recurrent disease following definitive therapy. So small number of recurrent patients, and these data do not apply to recurrent patients in my view. The median follow-up was 72 months for the combined arms. Analysis of the primary endpoint of metastasis-free survival showed that 6-year metastasis-free survival improved from 69% to 82% with a hazard ratio of 0.53, which translates into 47% reduction in the risk of metastasis with addition of abiraterone plus prednisolone to the standard of care definitive radiation therapy and androgen deprivation therapy. 6-year overall survival also improved from 77% to 86% with a hazard ratio of 0.60, which translates into 40% reduction in risk of death in patients who received 2 years of abiraterone plus prednisolone. Secondary outcome measures such as prostate cancer specific survival and progression-free survival were also significantly improved with addition of abiraterone plus prednisolone. Please note that addition of enzalutamide did not affect the efficacy of abiraterone and prednisolone. So enzalutamide did not make any difference to the efficacy, but may have increased the toxicity. So this is an important point to remember. To summarize the results from this study, 2 years of abiraterone acetate with prednisolone, when added to androgen deprivation therapy plus radiation therapy in high-risk non-metastatic prostate cancer, improved metastasis-free survival and overall survival, and should be considered a new standard of care for these patients. With that, let's move on to the PEACE-1 trial, which was presented at the ESMO 2021 meeting by Dr. Karim Fizazi from the Gustave Roussy Cancer Institute in Paris, in France. This was a phase 3 trial with a 2x2 factorial design in men with de novo metastatic castration-sensitive prostate cancer. In this trial, 1,173 men with newly diagnosed de novo castration-sensitive prostate cancer were randomized to one of the 4 arms. And we can see the 4 arms here. These include ADT, standard of care therapy, or standard of care therapy plus abiraterone, or standard of care plus radiation therapy to the prostate, or standard of care plus abiraterone plus radiation therapy. It is important to note that after approximately 300 patients were recruited on the PEACE-1 trial, the investigators changed the standard of care therapy in this trial from ADT monotherapy to ADT plus docetaxel chemotherapy. Therefore, in the rest of 710 patients, the standard of care therapy comprised ADT plus docetaxel, and then patients were randomized to these 4 arms. In this subgroup analysis of the original study, patients included for the analysis were those 710 patients who received ADT plus docetaxel as standard of care, and then were randomized to 4 arms of standard of care versus standard of care plus abiraterone, plus standard of care plus radiation therapy versus standard of care plus abiraterone plus radiation therapy. Among these 710 men, almost 2/3 had high volume disease. The results reported in the ESMO 2021 analysis compared the new standard of care, which was ADT plus docetaxel, to abiraterone with or without radiation therapy. So the abiraterone data were mature and radiation therapy data were not mature. So in this study, in this presentation, Dr. Fizazi focused on patients, those 710 patients who received standard of care ADT plus docetaxel versus standard of care plus abiraterone. So the experimental arm received ADT plus docetaxel plus abiraterone. Patient characteristics were well balanced between arms, and most patients had, as I said, had high disease burden. I would also like to bring to your attention that data for radiation therapy were not mature and will be presented in the meeting, one of the future meetings. So the co-primary endpoints were radiographic progression-free survival and overall survival. At the time of report in ESMO 2021, number of progression events required for abiraterone arm have been met, and hence the results were only reported on the efficacy of abiraterone on the radiographic PFS and overall survival. Radiographic PFS. In this slide, we can see here the Kaplan-Meier curve showing radiographic PFS. And it was significantly improved from 2 years to 4.5 years with addition of abiraterone to standard of care ADT plus docetaxel arm with a hazard ratio of 0.50 and a p-value of 0.001. Overall survival was also improved with the addition of abiraterone to the standard of care therapy of ADT plus docetaxel. Median OS with triplet therapy was 4.5 years. Sorry, the median OS with standard of care therapy without abiraterone, so ADT plus docetaxel, was 4.5 years and was not reached in the triplet therapy arm with ADT plus docetaxel plus abiraterone. The hazard ratio was 0.75 with a p-value of 0.017. Again, a significant improvement in overall survival by adding abiraterone to the backbone of ADT plus docetaxel. So now let's look at the OS benefit by volume of disease. In the high volume disease patients, addition of abiraterone to standard of care ADT plus docetaxel resulted in a 16-month improved median overall survival from 3.5 years to 5.1 years, with a hazard ratio of 0.72 and a p-value of 0.019. So clear improvement in overall survival with triplet therapy compared to ADT plus docetaxel chemotherapy. However, if you look at the low volume disease patients, addition of abiraterone to standard of care ADT plus docetaxel did not improve overall survival compared to ADT plus docetaxel. Based on these data, abiraterone should be offered to those men with high volume de novo metastatic castration-sensitive prostate cancer who are starting treatment with ADT plus docetaxel. So if we have determined that someone with high volume de novo metastatic disease is going to receive ADT plus docetaxel, adding abiraterone to that doublet arm is considered standard of care now. However, this trial did not answer the question whether adding docetaxel to patients who are receiving ADT plus novel hormonal therapy, such as abiraterone, improves outcome. So the trial does not answer the question whether docetaxel should be added to patients who are scheduled to start ADT plus abiraterone, for example. Hence, these data do not apply to those patients who are starting therapy with ADT plus a novel hormonal therapy. Before I move on to the VISION trial results in the metastatic castrate-resistant prostate cancer setting, I would like to bring your attention to the press release on the results of the ARASEN trial. In this trial, 1,306 men with metastatic castration-sensitive prostate cancer were randomized to ADT plus docetaxel versus ADT plus docetaxel plus a novel hormonal therapy, darolutamide, at 600 milligram BID. Primary endpoint was overall survival with multiple secondary endpoints. On December 3, 2021, a press release by Bayer announced prelim results from the ARASEN trial that addition of darolutamide to ADT plus docetaxel met its primary endpoint of significantly improved overall survival in patients with metastatic castration-sensitive prostate cancer. We are expecting to see the full data in one of the upcoming meetings. So let's move on to the results of the VISION trial presented by Dr. Mike Morris from Memorial Sloan Kettering Hospital in the ASCO 2021 meeting. The manuscript reporting these results were published recently in the New England Journal of Medicine and was led by Dr. Oliver Sartor from the Tulane University. Before we discuss the results of the trial, let's look at the mechanism of action of agent utilized in this study. PSMA is a transmembrane carboxypeptidase, which is highly expressed in the prostate cancer, including metastatic lesions, with relatively restricted expression in normal tissue, such as salivary and lacrimal glands. Due to PSMA's relatively high specificity, it makes for an ideal target for drug development and PET imaging. In this picture, we can see how a PSMA ligand bound to lutetium-177, a beta particle emitting radioisotope, can be used for targeted therapy. So PSMA-617 is a molecule with high affinity to PSMA protein expressed on the prostate cancer cells and is tagged with the beta particle emitting radioisotope lutetium-177. So intravenous injection of the molecule lutetium-177, PSMA-617, seeks and specifically binds to PSMA-expressing prostate cancer cells, which ultimately leads to internalization of lutetium PSMA-617. After internalization and getting inside the prostate cancer cells, beta radiation from lutetium-177 cause DNA damage and cell death. In this trial, eligible patients must have received prior treatment with at least one novel hormonal therapy, such as abiraterone or enzalutamide, and at least one taxane-based regimen. Moreover, life expectancy must have been greater than 6 months. Most importantly, patients were required to have at least one PSMA-positive metastatic lesion on a diagnostic PSMA PET scan. Patients with PSMA-negative metastatic lesions were excluded to make sure study does not accrue those patients with neuroendocrine prostate cancer. This was an open-label study where patients were randomized to the lutetium-177 PSMA-617 plus standard of care versus standard of care alone. Chemotherapy, immunotherapy, radium-223, or investigational agents were not allowed on the standard of care therapy arm. So these agents were not considered standard of care for this trial. So standard of care therapy on this protocol mostly included AR receptor pathway inhibitors or bone strengthening agents. Pre-specified alternate primary endpoints for radiographic PFS or per PCWG3 or overall survival. Alternate primary endpoints meant the study would be positive if either of these primary endpoints were significantly improved. Multiple secondary endpoints were also included, as we can see here, and included time to first symptomatic skeletal event, overall response rate, disease control rates, health-related quality of life, safety and tolerability, and biomarkers. It is important to note that 87% patients who were screened by a PSMA PET scan, in this case, gallium-68 PSMA-11 PET scan, met the VISION trial criteria for PSMA-positive metastatic castrate-resistant prostate cancer. So overwhelmingly vast majority of patients were positive for PSMA positivity as defined by the protocol. I will also bring your attention to this important aspect of this trial. So when the trial started enrollment in June 2018, the study saw a high dropout rate among patients who were randomized to the standard of care control arm. In fact, over 56% patients dropped out. So you can see here from June 2018 to March 2019, dropout rate for 56%. This led to a discussion between the study team and the FDA, which led to measures being implemented to reduce the dropout rate on the standard of care control arm. Once these measures were put in place, the dropout rate decreased from 56% to 16%. Consequently, radiographic PFS analysis only included those patients who were recruited after dropout measures were implemented. However, overall survival analysis included all 831 patients who were accrued on the trial, regardless of whether they were enrolled before the measures were implemented or after. So primary endpoint of overall survival, we can see here, was met with an improvement of 4 months from 11.3 to 15.3 months in the experimental arm with a hazard ratio of 0.62 and a p-value of less than 0.001. This translates into 40% reduction in risk of death with treatment of lutetium-177 PSMA-617 when added to standard of care therapy. The other alternate primary endpoint of radiographic PFS was improved by approximately 5 months with a hazard ratio of 0.40, which translates into 60% reduction in the risk of disease progression and a p-value of 0.001. Overall, objective responses were higher in patients on the lutetium-177 experimental arm, as we can see here. Overall, PSA responses were also improved in the lutetium-177 experimental arm compared to among the evaluable patients, with a clear improvement in PSA responses. Regarding the side effects, no unexpected or concerning safety signals were noted with the use of lutetium-177. As expected, and given that prostate cancer metastasis mainly involves bones and in turn bone marrow, PSMA, and the fact that PSMA is expressed in salivary gland and lacrimal glands, as well as kidneys to some extent, side effects were noted accordingly. So what were the side effects? They were associated with myelosuppression, as evidenced by anemia, thrombocytopenia, leukemia. Side effect because of involvement of lacrimal gland and salivary glands resulted in dry mouth. PSMA is expressed on kidney, as I mentioned. So we also saw increased creatine. Nausea and vomiting were more frequently observed in the lutetium-177 arm compared to the standard of care arm. So these were the expected side effects as expected based on the mechanism of action of the drug and the expression of the PSMA on the normal tissue. However, if you look at the grade 3-5 side effects, they were few in number in the experimental arm, and most frequent ones included anemia in 13% patients, and others were increase in creatine in 3.4% patients and nausea and vomiting in 1.5% patients. So overall, my assessment of the side effect is this is a pretty well-tolerated drug, especially given the population which was tested, elderly, frail population, which had progressed on multiple lines of therapies. So to conclude, based on these results, addition of lutetium-177, PSMA-617 to standard of care therapy in patients with metastatic castration-resistant prostate cancer after prior novel hormonal therapy and taxane-based chemotherapy improved overall survival as well as radiographic progression-free survival. Lutetium-177 therapy was well tolerated, and these findings warrant adoption of lutetium-177 PSMA-617 as a new treatment option for metastatic castrate-resistant prostate cancer. To conclude, 2021 was a historic year for our patients with high-risk non-metastatic prostate cancer, metastatic castration-sensitive prostate cancer, and patients with metastatic castrate-resistant prostate cancer. So we see developments in whole spectrum of prostate cancer, which is exciting. We saw novel drugs or approaches leading to significant improvement in survival outcomes. Even though this may be a wonderful news for our patients, we realize that none of these therapies can cure our patients, and that advanced prostate cancer remains a lethal disease. And hence, identification of novel molecular targets and biomarkers and continued emphasis on clinical trials remains a high priority. With that, I would like to thank you for your kind attention and acknowledge my friends and colleagues at the Huntsman Cancer Hospital who helped me with my presentation. Thank you very much.
Good afternoon, everyone. Thank you for joining us. Thank you, Gil Morgan, for putting together OncoAlert Colloquium 2022. We appreciate this opportunity. Today's talk is going to be about accelerating cures for kidney cancer. My name is Brian Lewis. I'm the president of KidneyCan. Here's today's topics. We're going to talk about our mission at KidneyCan, opportunities for grant funding, opportunities to collaborate and learn, and how we accelerate cures. Here are my disclosures. KidneyCan's received some support from the pharmaceutical industry as well as patients and caregivers worldwide. I'm a patient advocacy representative, and I'm on the board of directors of the IKCC and a lobbyist and a survivor. KidneyCan's mission is to accelerate cures. How do we do that? Well, through building awareness to the kidney cancer community and our ecosystem, we try to get advocates to come with us to Washington, D.C. and make their voices heard. That advocacy leads to federal funding or US tax dollars invested in medical research. That medical research, we hope, will help accelerate the cure for kidney cancer. So who is KidneyCan? Well, we're a group made up of patients and researchers and volunteers, and we bring an ecosystem together by providing information to patients at our Patient Resource Center, as well as bringing together patients and caregivers and researchers and clinicians at our town hall events. And how does kidney cancer research happen? Here in the United States, it requires people. And we take those people, this grassroots army that we've built, and we go to Washington, D.C., and we advocate for additional federal funds for medical research. To date, this past year, we've reached $50 million for kidney cancer research funding through the KCRP. So what's next? So we're propelling research through this funding that we're advocating for grants, and need collaboration amongst these researchers. And so what KidneyCan has done is created a summit to bring those kidney cancer researchers into one room. And we have that every October here in Philadelphia. Think about joining us at KCRS 22, October 6th and 7th of this year. It's going to be a hybrid meeting with global attendance, but it will be focused on basic science going towards clinical translation. All of that information can be found at kcrs.kidneycan.org. If you need funding for your research, consider going to this website to apply for some of this $50 million available for research. Thank you for your time. Thank you, Gil, and thank you for all the sponsors who made this possible.
Hi, welcome to the radiotherapy update on bladder, testis, and renal cell carcinoma. My name is Piet Ost. I'm a radiation oncologist working in the Iridium network, Antwerp, Belgium. I will be covering bladder, testis, and finally renal cell carcinoma. I will first start off with a very important publication on the type of fractionation we use in radiotherapy. We either use standard fractionated radiotherapy, delivering 64 gray in 32 fractions, or hypofractionated radiotherapy, 55 gray in 20 fractions. The data of two individual randomized trials were pooled together in a meta-analysis. The trials were the BC 2001 and the Beacon trial. Both trials actually looked at radiotherapy versus chemoradiotherapy or radiotherapy with another systemic agent in the Beacon targeting hypoxia. Nevertheless, as a standard of care, both radiation modalities, hypofractionation and normal fractionation, were allowed. Now, when they came up with the idea to pool the data of both fractionations, they wanted to look at which regimen would give us the better local regional control. So the pooled analysis is over 600 patients. And from this graph, you can see that the dotted lines lie on top or above the straight lines, the dotted lines being the hypofractionated radiotherapy. So this individual patient data analysis actually indicates that the local regional control is superior as compared to normal fractionation. This gives us the advantage of treating our patients faster. Another interesting finding from the study is that the very high control was actually feasible despite a high proportion of patients having an incomplete transurethral resection of the bladder, which often is considered as a prerequisite to go over to radiotherapy. However, this trial indicates that in patients where this would not be feasible, you can still go for hypofractionated radiotherapy and get a good local regional control. When looking at the toxicity, there appeared to be no difference in late toxicity, not at 2 years and not at 5 years. Please do take into account that 1 in 3 of our patients will develop grade 3 to 4 toxicity at the level of the rectum or the bladder, which is considerably high. An interesting abstract which was shown during ESTRO 2021 was that of the RADAR trial. The RADAR trial includes patients with muscle-invasive bladder cancer with 20 fractions or 32 fractions of radiotherapy, and they were randomized to standard radiotherapy, standard dose, or escalated dose adept radiotherapy. Concomitant chemo was permitted as per standard of care. In this specific analysis, they didn't look at the primary outcome. However, within each fractionation cohort, they did a non-randomized comparison of the proportion of patients having grade 2 or higher toxicity. They wanted to know which of the standard of care concomitant systemic agents actually would give rise to a higher probability of developing toxicity. The agents that were included in this trial were mitomycin C with 5-FU, gemcitabine, and carbogen plus nicotinamide, or cisplatin. As you can see, the upper 3 were the most commonly used modality, with cisplatin only used in 2% of patients. Now, we're looking at the details, and I'm only going to focus on the 20 fraction cohort because in the previous slide, I indicated that the 20 fractions probably is the new standard of care. Following that meta-analysis, we see that for GU toxicity, there appears to be no difference between the systemic agent being used. 50%, 45%, 44% of patients developing grade 2 or higher toxicity. So this appeared to be similar across the different systemic agents. However, there did appear to be a difference with gemcitabine, with the gastrointestinal toxicity rate being higher in these patients. So this is of interest when we think about delivering definitive radiotherapy or radiochemo to our patients. Maybe we are better off using mitomycin C or 5-FU. Of course, this is a non-randomized comparison, but does offer some interesting insights. What about postoperative radiotherapy for muscle-invasive bladder cancer? Is it worth revisiting? We all know that high-risk patients actually develop a pelvic recurrence in about 1 in 3 cases. And older trials already indicated that when you give adjuvant external beam radiotherapy, that risk is decreased. However, the trade-off is that the toxicity is quite high, especially when you use older modalities. In this specific non-randomized phase 2 trial, where volumetric arc therapy was used with daily image-guided radiotherapy, delivering 25 fractions up to grade 2 the pelvic lymph nodes with or without the bladder PET, they wanted to look if this toxicity would still be that high with this modern way of delivering radiotherapy. By looking at the details in the table, it appears to be that 1 in 2 patients develops genitourinary complaints. Of course, this was following cystectomy, so these patients had a neobladder. To minds, only 17 patients got a neobladder, but 1 in 2 of these patients will develop grade 2 plus toxicity. Looking at the gastrointestinal toxicity, up to 61% develops grade 2 toxicity temporarily, and up to 6% of patients grade 3 plus. This is far lower than what was seen in the older trials, where patients had up to 25% or higher grade 3 toxicities. So this indicates that further research is necessary, but as far as toxicity, this seems to be feasible. And when we looked at that potential reduction in developing pelvic recurrence, indeed, the 2-year pelvic or local regional relapse-free survival was 83%. which is far lower than the 30% of patients that should have developed a local regional relapse. However, when looking at the 2-year bladder cancer-specific survival, this is only 62%, and 1 in 2 patients develops metastasis within 2 years, indicating that although postoperative radiotherapy can reduce the number of patients developing that pelvic recurrence, a lot of the patients probably need systemic therapy, either in combination or very soon after surgery and or radiotherapy, because they will develop metastasis at distant sites. 2 interesting abstracts that were shown as well during one of the past conferences. One of them looking into the surgery-sparing approaches, so bladder conservative therapy, started with pembrolizumab, then a maximal TURB, followed with definitive chemoradiotherapy and pembrolizumab every 3 weeks. At 12 weeks post-op, again, TURB of the tumor bed was done. It appears to be that the 1-year bladder intact disease-free survival is 88%, which is very high. However, 1 in 3 patients develop grade 3 or higher adverse events, which is more or less comparable with what you expect if you would give chemoradiotherapy alone. However, the bladder intact disease-free rate appears to be a bit higher than what we are used to see with chemoradiation alone. So very interesting data. The same surgery-sparing approach, however, with different molecules. As you can see here, the 1-year bladder intact disease-free survival was 73%, so a bit lower as the previous study. And again, 1 in 3 patients developing grade 3 to 4 toxicity. So we are more looking into trying to spare patients cystectomy, but probably we need a combination with systemic agents. The question is, what is the ideal approach? We are still not there, but I hope that I've convinced you that the classical normal fractionation has gone. We have to give hypofractionation at this time, but which systemic agent is still out there to the jury. Testis. Normally, radiotherapy in testis doesn't have a lot of updates. However, a very interesting trial was shown during one of the conferences as well. And these were the results of the SAC-0110 trial. It was a phase 2 single-dose carbo with radiotherapy. So normally, if you consider seminoma stage 2 A or B disease, your 3-year relapse-free survival is around 90%, either with radiotherapy or with chemo. Typical radiotherapy is a dog-leg approach, para-aortic pelvic radiotherapy. And if patients do develop a relapse, this is mainly supradiaphragmal. If you give chemo, typically you give 3 to 4 cycles of a cisplatin-based combination. And if you relapse in that case, that's mainly in the retroperitoneum. So this approach in the SAC trial wanted to combine the best of both worlds. So for stage 2, they went for 1 cycle of carboplatinum. So the dose of chemotherapy is being reduced and involved node radiotherapy. Same for stage 2B, same chemotherapy, but radiotherapy dose to the involved nodal region was increased to 36 gray. So the radiotherapy is also being reduced because they don't use the extensive fields. They used up to only a quarter of the traditional volume that received radiation here. But with that combination with a reduced dose chemo, maybe the relapse-free survival is still as good with these reduced combination modality. And indeed, very interesting results. The overall 3-year progression-free survival, almost 94%. And that's what you're aiming for, slightly better, of course, for stage 2A as compared to 2B. Most common grade 3-4 events were thrombocytopenia and neutropenia. And as you can see, these rates are far lower when, as you would compare with your standard chemotherapy that you would give to these patients. 4 secondary primary cancers were found during follow-up. Of course, this is still too early, and we need longer follow-up to see if that rate remains fairly low. So very interesting results, and maybe this might develop into a new standard of care. Switching to renal cell. Renal cell carcinoma is typically considered a radioresistant tumor. However, the past year, 4 phase 2 trials were published although non-randomized, with oligo or metastatic renal cell carcinoma, actually delivering SABR or stereotactic ablative body radiotherapy alone, in combination with a TKI, or in combination with an immunotherapy agent. If you look at the column of the local control, you can see that the local control rates are typically above 90%. So 93, 94, 97% in these studies. So indicating that renal cell carcinoma actually is not radioresistant, especially if you give those higher ablative doses. So this myth actually should stop, and we shouldn't consider that as a radioresistant tumor, especially with modern techniques and higher doses. If we look at the toxicity, then in combination with a TKI and or immunotherapy agent, you can see that there is no increase in the toxicity, and the reported toxicity was mainly related to the systemic agent being delivered. So also that offers us new opportunities, because the first line treatment of patients with metastatic renal cell is switching from TKI IO to a combination. Of course, we don't have the answer here if we give that combination down with SABR, if that is also safe. But it appears to be that there is no safety signals that warrant us to stop giving SABR in these patients. One important study, wanted to highlight that Massini et al. Actually, what they did, they wanted to hunt for the abscopal effect. So what they had, patients with multiple lesions, they targeted one lesion, not trying to give SABR to all metastatic disease, but targeting one lesion in combination with nivolumab and looking at the response rate. However, both response rate and the progression-free survival was only 5.6 months. In comparison, with the other trials reported in this table, where all metastases received radiotherapy and a systemic agent, and even to the paper of Chung et al., where none of the patients actually received a systemic agent, it appears to be that if you go for radiotherapy, irradiate everything you see. That appears to be the best approach. So don't try to go for that abscopal effect, because that does not appear to exist in renal cell with these doses or with these drugs that are being used. So either irradiate everything or just give your systemic therapy. Of course, we don't know, or still don't know, if we should deliver radiotherapy in the setting, and trials are running, one example being OligoRare by EORTC, comparing standard of care versus standard of care with SABR to all the lesions. So stay tuned for that, and hopefully in a few years we have those results. So for me to conclude, for bladder cancer, hypofractionation is now standard of care. Watch out for the gemcitabine radiotherapy combination that might have more gastrointestinal toxicity. For seminoma, a new and interesting approach, reducing dose of systemic therapy, reducing the volume of radiotherapy, appears to be an appealing combination. Renal cell carcinoma actually should not be considered radioresistant. Radiotherapy can be safely combined with a TKI and IO. I thank you for your attention, and I'm happy to answer any questions on Twitter. Thank you.
Hi, everybody. My name is Sean McBride. I'm an associate attending and chief of the Manhattan service at Memorial Sloan Kettering. I'm a radiation oncologist. I'm here to present critical radiation trials in prostate cancer in 2021. I'm very pleased to be here. I've chosen 4 trials to discuss. We'll be discussing POP-RT, a trial of elective pelvic nodal irradiation in definitive prostate cancer. We'll be talking about the FLAME trial, a trial of focal radiation dose escalation to intraprostatic disease. We'll be talking about STAMPEDE, in which one of the arms looked at the addition of ARSIs to standard ADT in N0 and N positive, but M0 patients treated definitively with radiation. And we'll look at RTOG 0815, a trial examining the use of short course androgen deprivation therapy in patients with intermediate risk prostate cancer. To start with POP-RT. This is a trial run out of Tata Memorial Hospital again, that looked at whole pelvic radiation versus prostate-only radiation in high-risk and very high-risk prostate cancer. The eligibility you can see here, these were patients with newly diagnosed prostate cancer. They had to be N0, M0 as staged by either a PSMA PET scan, and 80% of these patients had a PSMA PET scan, or conventional imaging, CT, bone scan, MRI. Patients had to be NCCN high risk or very high risk. Just a point here, they used the Roche formula, but the Roche formula calculations that they used essentially meant that they enrolled only high risk or very high risk patients in equal proportion. And patients had to have a life expectancy of greater than 5 years. The endpoints were biochemical failure-free survival as defined by the Phoenix definition, which is the nadir PSA value plus 2 nanograms per milliliter. An important exploratory endpoint that they examined was distant metastases-free survival. Patients were randomized 1-to-1 to prostate only radiation or prostate and pelvic RT. Patients were stratified by PSA and by Gleason score. The prostate treatment was 68 Gray and 25 fractions. The pelvis was treated to 50 Gray and 25 fractions. The pelvic nodal volumes, and this is an important point, were delineated based on RTOG 2009 nodal contouring atlas. Since that time, the RTOG atlas has been updated and includes more of the pelvic nodal basins. ADT was used in these patients for 24 months in all patients, regardless of the arm. Here's a consort diagram. So they assessed 336 patients, 224 were randomized. And in the final analysis, there were 110 patients in the whole pelvic arm and 112 in the prostate only arm. There were very few treatment discontinuations and here are the outcomes. You can see on the left, the Kaplan-Meier curves. Here at A, we're looking at biochemical recurrence-free survival. Here are the actual numbers. 5-year biochemical recurrence-free survival was superior in the whole pelvic arm compared to the prostate-only arm, 95% versus 81%. The hazard ratio was significantly lower, 0.20 for the whole pelvic RT. And obviously, this was a statistically significant finding. I think most interesting, and again, this is an exploratory analysis, you look at distant metastases-free survival. And here in distant metastases-free survival, there was a superiority to whole pelvic RT, 95% versus 87.9% at 5 years. Again, the hazard ratio was substantially lower for whole pelvic RT, and the finding was statistically significant. I think what's important to note here is that these patients were assessed for distant metastases very soon after their biochemical failure, and most of them were assessed, the vast majority were assessed with PSMA PET scans. And the use of the PSMA PET scans to assess distant metastasis was, in a subsequent communication to JCO, the authors pointed out, balanced between both of the arms. There was some criticism that there might be some bias related to differential use of the PSMA PET between the two arms to assess for distant mets, and that does not appear to be true. On the subgroup analysis, important things I want to point out are, first of all, the variables by which they stratified. There was no difference based on Gleason score in terms of the benefit of biochemical failure-free survival. There was no difference based on PSA, again, the variable which they stratified. It was a categorical stratification greater than or less than 50. There was no difference. This was a post hoc analysis looking at differences between the high risk and very high risk group. There was no difference in terms of biochemical failure-free survival benefit when you compare the high risk to the very high risk with the addition of pelvic nodal irradiation. And you can see the P for interaction for almost all of these was insignificant, meaning there was no difference between these two groups in the benefit that they derived from pelvic nodal irradiation. There was a difference in age. Patients greater than 66 tended to derive less benefit than patients less than 66 in terms of biochemical failure-free survival benefit. It's hard to understand why that might be the case, but that was a finding that they made. Toxicities. The one thing I would note here is that there was a significant difference in the rate of RTOG. This is not patient reported, this is physician reported outcomes. There was a difference in the rate of grade 2, 3 RTOG urinary toxicities when you compared the two arms. The authors hypothesized that that difference may have been related to more of the bladder being exposed to the 30 to 40 gray region of radiation. So POP-RT conclusions. Why was POP-RT positive but RTOG 9413 and the GETIG trial that asked similar questions negative? Well, this was likely a result of improved staging in POP-RT. Again, 80% of these patients were staged with PSMA PETs and perhaps more extensive nodal irradiation. I mentioned the RTOG 2009 atlas is less extensive than the current atlas in use. Compared to the RTOG 9413 and GETIG trials, the RTOG 2009 atlas had a more extensive volume of nodes irradiated. And so in POP-RT, using that atlas, they irradiated more of the pelvic nodal basins than in the RTOG trials and the GETIG trials. My take, for PSMA PET staged NCCN high risk and very high risk patients, which at least in the United States and obviously in India and increasingly across the world is becoming the standard of care for imaging at upfront diagnosis for high risk and very high risk patients. Elective nodal radiation is standard of care for those who have negative PSMA PET imaging in the pelvic nodes. Unanswered questions. I think an unanswered question, and we'll talk about STAMPEDE in a little bit, is the benefit of pelvic nodal RT when added to prostate-only radiation with ADT and abiraterone. That's unclear. In my opinion, it likely still will have some significant biochemical recurrence-free survival benefit, but the magnitude of that benefit is likely attenuated with the addition of abiraterone. The next trial I'd like to talk about is the FLAME trial. This is a focal boost to the intraprostatic tumor and external beam radiotherapy for patients with localized prostate cancer. This was a phase 3 randomized trial. Eligibility: patients had to have newly diagnosed prostate cancer, be N0, M0 with EAU intermediate or high risk disease, which maps well on NCCN risk categorizations. They had to have an IPSS less than 20. The endpoints were biochemical disease-free survival, again like POP-RT based on the Phoenix definition. The authors also looked at distant metastases-free survival, prostate cancer-specific survival, and overall survival. The treatment: patients were randomized 1-to-1 to standard radiation. That was 77 gray and 2.2 gray fractions to the entire prostate, or that dose with a focal single integrated boost to 95 gray to multiparametric MRI-defined tumor. There was no nodal RT in these patients, and ADT use, importantly, was at the discretion of the treating physician. So here's the consort diagram. 571 patients were randomized. The intention to treat analysis was 276 in the standard arm and 281 in the focal boost arm. Per protocol analysis, there were slightly fewer patients, as is typically the case. What were the results? So here in box A, you can see the biochemical disease-free survival favored the focal boost arm. Median follow-up was 72 months. In the standard non-boost arm, 5-year BRFS was 85%, and in the boost arm, it was 92%. That was statistically significant, and the adjusted hazard ratio, adjusted for typical variables like PSA, Gleason score, was much lower, 0.45 for the focal boost arm. Important to note, distant metastases-free survival, overall survival, and prostate cancer-specific survival, there was no statistically significant difference between the arms. Although I will say that in a subsequent publication, the FLAME authors showed that regional, when a composite endpoint of regional and distant failure, there was a benefit for focal boost to the prostate in reducing the sum of regional and distant failures. So there were fewer regional distant failures in the boost arm than there were in the standard arm. That was dominated by regional failures. Difference in toxicity: there was no statistically significant difference in toxicities, either GU or GI, between the arms. And the authors surmised this was because of their strict adherence to their OAR constraints. My takeaway from the FLAME trial is for conventionally fractionated patients, Single integrated boost to gross disease provides a biochemical disease-free survival. I think that's an endpoint that has inherent meaning. And because of that finding, a boost to MP-MRI defined gross disease should be a standard of care for conventionally fractionated patients. Now, there is a push based on strong evidence to use moderate hypofractionated radiation when treating definitively. How to integrate into moderate hypofractionated regimens. I don't think that's a complicated question to ask. I think you could surmise that a focal boost in moderate hypofractionated patients, if you strictly adhere to OAR constraints, will provide you the same biochemical recurrence-free survival benefit. What I think is not clear is whether in extreme ultra hypofractionation, a single integrated boost is going to provide benefit. You can see back the magnitude of the biochemical recurrence-free survival benefit is not significant. And in some of the ultra hypofractionated regimens, our own included, we're delivering 8 Gray times 5 to the prostate. And using the alpha beta assumptions of the trialists in FLAME, we would have been delivering the equivalent of their boost dose to the entire prostate. So whether additional boost on top of that is going to provide real benefit is uncertain. Frankly, I'm skeptical, but the trialists have opened up a new protocol, HypoFlame, where the whole prostate is getting 35 Gray and 5 fractions of the prostate with a single integrated boost to 50 Gray and 5 fractions to MP-MRI defined gross disease. Next trial. This is STAMPEDE, a very prolific multi-arm, multi-stage protocol. And here we want to look at abiraterone with or without enzalutamide for high-risk non-metastatic prostate cancer. This is a meta-analysis, primary results from 2 randomized controlled phase 3 trials of the STAMPEDE multi-arm, multi-stage platform. Eligibility for these 2 trials. Patients had to be N positive or N0. If they were N0, they had to have at least 2 of the following, either Gleason 8 to 10, T3, T4 disease, that included MRI stage T3, T4 disease, and a PSA greater than 40. They had to be M0 by conventional imaging. Primary endpoint here was metastasis-free survival, but they also looked at overall survival, prostate cancer-specific survival, and failure-free survival. So the treatment, patients were randomized between ADT times 3 years versus ADT plus Abi plus minus enzalutamide. So these were 2 trials. The first trial, this is a meta-analysis, these were 2 trials. The first trial looked at the addition of Abi compared to standard ADT. The second trial looked at the addition of Abi and Enza compared to standard ADT. The ARSI therapy was continued for 2 years. For the N0 patients, RT was mandated, 74 Gray and 37 fractions. For the N1 patients, it was strongly encouraged. Patients were stratified by age and nodal involvement, amongst other variables. Here's the consort diagram. So 5,500 patients were randomly assigned to treatment. 914 to the non-metastatic patients were allocated to the Abi trial. 1,060 patients were allocated to the Abi Enza trial. And then there were 1,919 patients assigned to either trial. And you can see for the Abi and the Enza trials, you can see further breakdown into the controls and the combo. So 455 allocated to the control group for the Abi trial, 459 allocated the combo group in the Abi trial, that's Abi and ADT. For the Enza trial, 533 allocated to the control group, that's just ADT, and 527 were allocated to the combination of Abi and Enza. Here's the table 1 data. One thing I want to point out is that, as we would expect, because of the protocol requirements, the vast majority of patients received radiation. 82% in the control group in the Abi trial, 88% in the control group in the Abi and Enza trial, 81% in the combo group in the Abi trial, and 89% in the combo group in the Abi and Enza trial. They were otherwise well balanced on all other factors. So what are the outcomes? So because there was no difference comparing Abi to Abi and Enza, the experimental arms were grouped together. And you can see that because there was no evidence for between trial heterogeneity or treatment interaction comparing ADT and ABI to ADT, ABI, and ENZA. So ENZA didn't provide any benefit above and beyond ABI. So those two experimental arms were grouped together. And these are combined results for the grouped arms compared to control. So the median follow-up was 72 months in the ABI trial and 60 months in the ABI-ENZA trial. The 6-year metastasis-free survival for the combo group was 69%. Sorry, this is reversed. It should be the combo group is 82% versus the ADT alone is 69%. And that was significant. Hazard ratio was 0.53. Most impressively, the overall survival, the combo group was 86% at 6 years, and the ADT alone group was 77%. That's a substantial improvement in overall survival with the addition of abiraterone to standard ADT in N0 and positive patients getting radiation. You might ask, well, was there a subgroup? Was there some differential benefit looking at various subgroups? And the answer to that essentially is no. There was the P for interaction was not significant for age at randomization or nodal status. There was a difference in performance status. When you looked at patients who were poor performers, there was no benefit for metastasis-free survival. There didn't appear to be in poor performing patients, which is as you would expect because there are competing risks there that may have precluded the benefit in terms of metastasis-free survival. But what's interesting, though, is that on overall survival, you also don't see any differential benefit, meaning patients greater than or less than 70 benefited in terms of overall survival with the addition of ABI. Node-positive patients benefited with the addition of ABI. WHO performance status patients, they also benefited. So it's a bit discordant between MFS and OS when it comes to performance status evaluation. So I wouldn't take performance status too much into account when deciding whether to administer abiraterone. Obviously, there's a lot of competing mortality risk, and there are some ineligibility requirements for STAMPEDE based on comorbidities that may impact your decision to give abiraterone. But because of the discordance between MFS and OS with regards to differential impact of treatment based on performance status, I wouldn't rely too heavily on that in your decision of whether to include abiraterone with radiation in these very high risk patients. Toxicities, what I would point out is that hypertension and transaminitis was more common in the combo arm. And those are known toxicities of abiraterone. So my take, for very high risk N0 or for N-positive prostate cancer getting radiation, abiraterone added to ADT should be a standard of care. And typically you would give that for 24 months. That's what was done by the trialists. Unanswered question, would the addition of pelvic nodal RT, this is the converse of the question we asked for POP RT, would the addition of pelvic nodal RT have blunted the impact of DMFS that we saw in the STAMPEDE? I think that's unlikely given the magnitude of the benefit. We also saw a huge overall survival benefit with the addition of abiraterone. And recall from POP RT, we did not see that. And the follow-up was similar between the two trials. So I do not think it is likely that elective pelvic nodal irradiation, which was not done in the STAMPEDE trial, would significantly blunt the DMFS and OS benefit with the addition of ABI. Our final trial to look at is RTOG 0815, which is dose-escalated radiotherapy alone or in combination with short-course ADT for intermediate risk prostate cancer. The background here is there's a lot of conflicting data, I think, on the benefit of ADT with dose-escalated EBRT. The conflict is whether or not you derive a significant distant metastases-free survival benefit with short-course ADT. So RTG 0815, the eligibility, they had to have intermediate risk prostate cancer. Importantly, intermediate risk patients with greater than 50% positive cores or all three intermediate risk factors were excluded. Endpoints, primary endpoint was overall survival. Secondary endpoints were biochemical failure, local failure, distant mets, and prostate cancer specific mortality. Treatment, all patients got dose escalated EBRT, and that could either be RT to the external beam alone, 79.2 gray to the whole gland, or brachy combo, HDR or LDR. And then patients were randomized to 6 months of ADT. Importantly, the ADT included LHRH agonist plus an anti-androgen like bicalutamide. Patients were stratified by RT type, ACE27, which is a measure of comorbidity, and the number of risk factors. Some table 1 data. You can see 85% of these patients were over 60. I think there's a good proportion of minority patients that were enrolled in this trial. 67% of these patients had a single intermediate risk factor. The vast majority of patients, almost 90%, received EBRT alone, not brachy combo. And you can see the data on median PSA. 92% were Gleason 7, and on T-stage, most were T1C. The primary endpoint, there was no difference between the arms, RT alone versus RT and short course ADT. The hazard ratio crossed 1, and the findings were not significant. But you can see the numbers here. But for PSA failure, there was a significant difference at 5 and 8 years. That difference, the hazard ratio for that was substantially lower, favoring the short course ADT arm. For distant metastasis, there was a significant difference. 4.3% versus 1%, favoring the short course ADT arm. The hazard ratio, much lower, and that reflects the relative magnitude of the difference between these two, not the absolute difference, which is relatively small. Prostate cancer specific mortality, there was a significant difference. No one in arm 2, the short course ADT arm, died from prostate cancer, but 10 patients, one patient in the short course arm, but 10 patients in the RT alone arm. And you can see the cumulative incidence estimates of prostate cancer specific mortality at 5 and 8 years, favoring the short course ADT arm. By subgroup analysis, there was no difference in the benefit derived for PSA failure, comparing patients with 1 risk factor, 2 to 3 risk factors. There was no difference by ACE27 subgroup, which again is a measurement of comorbidity. There were so few patients getting combo that the confidence intervals for the hazard ratio estimate crossed 1, but you can see there is a similar magnitude of the difference comparing EBRT alone to combo. And then there was no difference comparing Gleason 3+4 to Gleason 4+3 patients. Distant metastases, again, there are much fewer events, so they couldn't really evaluate, they couldn't really evaluate the RT modality question, but again, the magnitude of the difference is similar. But there was no difference by number of risk factors, and there didn't appear to be a difference between Gleason 3+4 or Gleason 4+3. So patient-reported QOL outcomes, bringing them up here. Obviously, there were temporary dips because of the hormone therapy side effects, both in terms of the typical ADT-associated side effects like hot flashes and fatigue, and the impact of ADT on sexual function. But by 60 months, though there did not appear to be any residual significant difference. There was no difference, as we would expect, between urinary and bowel toxicities comparing the 2 arms. So my take, for unfavorable intermediate risk patients getting conventionally fractionated external beam radiation, they should get short course ADT. For unfavorable intermediate risk patients getting brachy combo, the patient should likely get short course ADT. And I think the cipher is a reasonable way to try to triage those patients. For favorable intermediate risk prostate cancer patients getting dose escalated EBRT, you should consider short course ADT. I think if they're Gleason 6 and they're unfavorable intermediate risk simply by PSA alone, you should probably be considering active surveillance. But if you're treating, you certainly shouldn't be considering ADT. But if they're favorable intermediate risk because of Gleason 3+4 and 2 or 3 cores, then I would consider running Decipher to determine the benefit of short course ADT. Unanswered questions: how can we further determine which intermediate risk patients will benefit from short course ADT? In Energy GU010, a critical trial being run by Ale Berlin and Neil Desai, I think will give us further insights in a few years.
Hi, my name is Ravindran Kanesvaran. I'm a medical oncologist at the National Cancer Center, Singapore. I'm also currently the president of the International Society of Geriatric Oncology. At this juncture, I would like to thank Dr. Gil Morgan and also the OncoAlert team for their kind invitation to partner with OncoAlert to present to you geriatric oncology updates for 2021. These are my disclosures. So the geriatric oncology updates will be divided into two parts. The first part will be presented by me, and the next section will be presented by my colleague, Dr. Nicolo Battisti, who's the president-elect of SIOG. The outline of my talk will include the following. I'll briefly introduce the International Society of Geriatric Oncology, followed by a short discussion on geriatric oncology public policy initiatives in 2021, some updates on research, and finally, I will summarize. The International Society of Geriatric Oncology was founded in the year 2000. It's a leading international organization in this field of geriatric oncology, where we look at how we can improve the lives of our older adults with cancer. We have over 1,900 members from 80 countries, and we come together yearly to discuss and share the latest research and development in the field. We also conduct educational events, webinars, and one of our signature events is our advanced course. And these courses are run globally throughout the year to educate oncologists on the role of geriatric oncology in our daily practice. Of late, over the last couple of years, we have also started to collaborate with oncology and non-oncology organizations globally to develop this field in a bigger way. Now, here are some of our initiatives in 2021. We run 2 advanced courses a year, and in 2021, we ran one in Canberra, Australia. This was done virtually across over 2 days in January, and we will run our next one pretty soon. We also have our signature course, the Treviso course, which has been running for over 5 years now, and this was held in December, and this was held in person, as we usually would. We could not have this course last year because of the pandemic. And in these advanced courses, we look at workshop style type of educational activities, where it's small group, where attendees get to learn firsthand from experts in the field about fundamentals in the field of geriatric oncology. We also had an ESMO SIOG preceptorship. This was conducted by the ESMO SIOG Cancer in the Elderly Work Group that was established for more than 2 years now. This was held as a virtual meeting. We also conducted numerous virtual meetings with the assistance of our geriatric oncology colleagues in India, in Turkey, Hong Kong, Singapore, Europe. We conducted a number of events with industry partners, and we also collaborate with other oncology organizations like UICC, ESMO, SPCC, and we work very closely with our colleagues in the European Union, specifically on the H2020 projects, and also the EU Parliament, propagating the importance of geriatric oncology in the field of oncology. Last year, we received special consultative status with the United Nations Economic and Social Council, ECOSOC. So this puts us as an important player in the field of geriatric oncology and the propagation of knowledge in this field to physicians, oncologists, non-oncologists, people who care for older adults with cancer. So our public policy initiative started about a decade ago, and this was initiated by Dr. Martine Exterman from the Moffitt Cancer Center, and she led a group that published this in the Journal of Geriatric Oncology, which is our official journal, in 2011. At that point in time, the group outlined 10 priorities that were thought to be important to address issues pertaining to cancer in the elderly. Now, they were broadly divided into 3 broad categories, namely education, clinical practice, and research. In terms of education, one of the goals was to increase public awareness of worldwide cancer, to work with medical societies, advocacy networks, integrate geriatric oncology into the curricula of medical and nursing education. And this is something We have pushed very hard, and a number of countries have incorporated this even at the medical school level. We also wanted to address the shortage of specialists both in oncology and geriatrics, and allied staff, health staff to support as well. In terms of clinical practice, we felt it was important to develop interdisciplinary geriatric oncology clinics. However, this had to take into account that resources were scarce in many countries, especially pertaining to the availability of specialists in the field. So we had to find ways to address this as well. The other issue was access to care, including the needs of the caregiver. In terms of research, the goal was to develop and disseminate early screening, easy screening tools, create a clear operational definition of vulnerability and frailty applicable to oncology, help in terms of designing clinical trials that will incorporate more older adults, which unfortunately is a group that is poorly represented in clinical trials at present. So in 2019, it was felt that it was time to update these SIOG 10 priorities. And Dr. Esterman formed another group again, this time focusing on 8 key areas that the group felt was important to be addressed. And this culminated with the presentation of the SIOG 12 priorities at the IFA, or International Federation of Aging, and SIOG jointly organized global dialogue at the United Nations in Geneva. We have also now formally formed the SIOG Public Policy Committee in 2021, which obviously is led by our public policy expert, Professor Martin Esterman. So in January 2021, the group published this in Lancet Oncology, looking at 12 priorities. And this time we had an additional pillar, and that was on collaboration and partnerships. So apart from updating the 10 priorities and dividing them again into education, clinical practice, and research, there was an additional pillar of collaboration that was added that looked at developing and strengthening links between SIOG and the geriatric oncology workforce, promote the inclusion of specific provisions for delivering high-quality evidence-based care for older adults in national cancer control plans. And finally, to create a global funding mechanism aimed at fostering professional development in geriatric oncology workforce, something that's really lacking at this point in time. Now let's briefly go through some research updates. So this was presented at ASCO 2021, and this study looked at real-world outcomes in older adults with cancer, and it was a retrospective study, a relatively large one, looking at over 2,049 patients. In terms of methods, this study ran across 12 different centers with data being collected from June 2016 till September 2018. And patients receive either immune checkpoint inhibitor monotherapy or doublet combination for malignant melanoma, non-small cell carcinoma, and renal cell cancer. IRAEs that were graded as grade 2 or above were considered clinically significant and recorded as per CTCAE version 5 guidelines. Now, the results clearly showed that patients, there was no difference in terms of survival benefit across all age groups. And this was similar to many other prior studies that we had seen. And more importantly, the data also supported the safety of these drugs in this group of patients. So that brings me to discuss the JCO special series on caring for older adults with cancers. This is the third iteration of such a special series with a focus on geriatric oncology. This was led by Dr. Dale, Dr. Jacobson, and Dr. Mohili. And as part of the series, there were a number of systematic reviews that were done, one of which focused on immunotherapy, which I was part of, which I'll give you an example of, but there was also systematic reviews done on targeted therapies and chemotherapy as well. So I'd strongly encourage you to read this series of articles. So for example, in the immunotherapy systematic review, the group looked at key survival data from phase 3 clinical trials and nicely broke it down into the setting for the clinical trial, whether it's first line, second line, the specific data with regards to the clinical trial, including number of patients and the ages of the patients enrolled into these trials, and broke them down broke the survival data into specific age groups, whether they were less than 65, 65 and older, and more than 65. In terms of toxicity as well, as far as possible, the group tried to look for data that stratified patients by age group and the grade of toxicity experienced, specifically focusing on significant toxicities, meaning grade 3 or higher toxicity. Although in terms of toxicity, the data is not as elaborate as what we have for survival. Nevertheless, what it did show is that in general, older adults benefited just as much as their younger counterparts when receiving immunotherapy in terms of survival. In terms of toxicity, there were some studies that did show older patients, specifically those who were 80 years and above or 75 years and above, seem to have a slightly higher risk of experiencing grade 3 or higher toxicity. But many of the studies actually did not show much of a difference in terms of safety and toxicity as well, showing that this group of drugs are actually relatively safe to be used in older adults with cancer. Now, another study that was presented at ASCO was focused on an area that has seen a lot of interest over the last few years. Just about a year before at ASCO 2020, there were 4 studies or 4 randomized control trials that were presented looking at the role of not just geriatric assessment, but intervention in this group of patients and its benefit. Some of these studies had shown a reduction in treatment toxicity. Others showed that these patients were able to complete treatments with no detriment to their survival while getting reduced doses. They had better quality of life. They also had fewer unplanned emergency room visits and hospitalization. Hence, based on that, this was another study to add to that pool of data conducted by our colleagues in Canada. This was the Comprehensive Geriatric Assessment and Management for Canadian Elders with Cancer, the 5C study. As you can see here, the study design basically included patients from 8 centers across Canada. About 350 patients were enrolled, and they were randomized into the intervention arm, where they received a geriatric assessment and at minimum monthly phone calls by a registered nurse for 6 months and reassessment by a medical doctor as needed. Compared with the control group, which received usual care. In terms of outcome assessment, quality of life measurements were done based on the EORTC QLQ C30 survey each month for the first 6 months, at month 9 and month 12 as well. Data from medical chart included cancer diagnosis, stage of treatment plan, and treatments received. Now, more importantly, prior to that, these were the studies that were presented at ASCO 2020, have now been published. And I would strongly encourage you to go through these papers. The first one published in The Lancet, this was evaluation of geriatric assessment and management on the toxic effects of cancer treatment, the GAP 70+ study, a cluster randomized study by Dr. Mohili and group. And more data from this will be presented by my colleague Nicolo in a short while. And the next study was the GAIN study. This was a single standard study looking at chemotherapy-related toxic effects in older patients with cancer. And this was a randomized controlled trial. Both actually showed benefit for the use of geriatric assessment and intervention in older adults with cancer. Now, going back to the Canadian study, the results of the study actually showed, unfortunately, there was no difference in terms of global health scale, EORTC, C30, quality of life measurements. As you can see here, looking at both the red and the blue lines, the red line actually was the intervention group, and they did not seem to do better than the control arm. And these measurements were done, as mentioned to you, monthly for 6 months, and then at month 9 and 12. In terms of secondary outcomes, looking at instrumental activities of daily living, again, here relatively mixed data, but nothing showing superiority of the intervention arm over the control arm. Hence, these results were relatively disappointing. However, the authors did mention there were a number of limitations of studies, including the dropout effect. A number of patients had dropped out. And one of the key reasons for this was the fact that this study only completed and just about completed enrollment at the start of the pandemic. And that meant for a number of these follow-up measurements, many patients did not actually get their measurements done. And this impacted the quality of the data and the results that we see in front of us. So that, again, clearly proved that the pandemic did have an impact on a number of research endeavors that our colleagues have embarked on. Unfortunately, that's been the case in many centers and across many studies globally. So in summary, SIOG is leading the way in the promotion of geriatric oncology principles globally. Public policy initiatives and new collaborations over this past year has expanded the reach of SIOG to many parts of the world, and a number of systematic reviews, specifically on the role of systemic therapies in geriatric oncology, have been published in 2021, and this can actually help guide the effective use of these treatments in a group of patients who are underrepresented in clinical trials. Publication of 3 RCTs on the benefit of geriatric assessment and intervention has established the clinical utility of geriatric assessment as an integral part of the management of older adults with cancer. Before I end, I would like to highlight one of our advanced courses, and I hope because this is done virtually, that many of you will be able to sign up. You can just get on the SIOG website, www.siog.org, and this will be conducted from January 22nd to 23rd. So if you do have the time and you want to learn the essential principles, basic principles in geriatric assessment and treatment, please get onto this course. And I would like to also encourage you to join us as a member of SIOG, especially if there are no members in your country and you want to promote the right treatment and the use of therapies in older adults with cancer. It will be great to have you as our member and also a representative for your country as well. With that, I would like to thank you for your attention and also wish everyone a great start to 2022.
Hello, everybody. My name is Nicolo Battisti, and I'm a medical oncologist at the Royal Marsden Hospital of London in the UK. My main clinical and research interests are breast oncology and geriatric oncology. I am the president-elect of the International Society for Geriatric Oncology, SIOG. Today, I will present some key updates in the field of geriatric oncology that have been published in 2021. These are my disclosures. I will start presenting the findings of 2 clinical trials, GAP70+ and GAIN, that defined integrated oncogeriatric care as a gold standard for the management of cancer in older individuals. Then I will move on describing 2 studies, GO2 and Bridging the Age Gap, that have investigated specific interventions and their outcomes for specific cohorts of older patients with cancer that are role models for the design of clinical trials in geriatric oncology. Finally, I will discuss the SIOG and USOMA recommendations for the management of breast cancer in older adults and draw a few conclusions. 2020 and 2021 have been remarkable years for the field of geriatric oncology. As 2 landmark clinical trials presented at the 2020 ASCO annual meeting and published only a few weeks ago in manuscript format, now provide compelling evidence supporting the integration of an oncogeriatric approach in the management of older adults with cancer. The GAP70 study was published on Lancet by Dr. Mohile from the University of Rochester, New York, in the US. The study enrolled 718 patients aged 70+ with incurable stage 3 to 4 cancer and more than 1 impaired geriatric assessment domain other than polypharmacy, deemed not suitable for best supportive care alone, and due to start a new chemotherapy regimen or other systemic agents with a similar toxicity risk. This was a cluster randomized study conducted in 41 community oncology practices with recommendations sent to the primary oncologist based on geriatric assessments versus usual care. The primary endpoint of the study was the rate of severe grade 3+ toxicity, and secondary endpoints included non-hematological toxicity, survival at 6 months, and impacts on treatment decisions. In this study, the intervention involved a geriatric assessment summary and recommendations for impairments being sent by the University of Rochester team to the treating oncologist in the experimental arm. Patient characteristics were well balanced between the 2 arms, with a median age of 77 years and the prevalence of gastrointestinal, genitourinary, and lung malignancies. 22% of these patients had received prior chemotherapy. In this population, more than 90% of patients had physical performance impairments, more than 80% polypharmacy, more than half functional impairments or nutritional impairments. Approximately 1/3 had cognitive impairments, 1/5 had social support problems, and less than 1/3 psychological issues. The study documented a statistically significant improvement of the rate of severe toxicity in the experimental arm compared with the standard arm, 51 versus 71%, along with the reduction in non-hematological toxicities, 32 versus 52%. Interestingly, the lower rates of adverse outcomes are explained by higher rates of the dose reduction in cycle 1 in the experimental versus the standard arm, 49 versus 35%. However, these benefits were not associated with any statistically significant differences in survival 6 and 12 months between the two study arms, suggesting that dose reductions may actually not have any impact on treatment efficacy in this population. The GAIN study was published in JAMA Oncology by Dr. Lee from the city of Opal, Duarte, California, in the US. Here, 605 patients aged 65 plus with solid tumors of any stage and commencing a new line of chemotherapy were randomized to usual care plus genetic assessment-driven interventions versus standard care alone, following a baseline genetic assessment. The study was conducted in the city of Hope, which is obviously a large academic center in Southern California, and the primary endpoint was the rate of grade 3 plus chemotherapy toxicity, with secondary endpoints including advanced directed completion, unplanned hospitalizations, emergency room visits, and average length of the inpatient hospital stay. In this study, the intervention in the experimental arm involved a baseline genetic assessment that was then reviewed by a multidisciplinary study team, issuing specific recommendations on interventions and referrals based on the genetic assessment results. The plan was reviewed with the treating oncologist and the patient, and chemotherapy was given at discretion of the treating oncologist, and patient underwent also a genetic assessment at the end of the study. In the standard arm, patients underwent a genetic assessment at baseline and end of study, but these results were reviewed only by the treating oncologist. In this study, patients had a median age of 71 years and were mostly diagnosed with gastrointestinal, breast, lung, or genitourinary malignancies. Patients' characteristics and genetic domains were well balanced between the two study arms. In this population, the study documented a statistically significant reduction in the rate of grade 3 plus chemotherapy-related toxicity, 50 versus 60%, with an absolute risk reduction of 9.9%, along with statistically significant improvements in the rate of grade 3 plus hematological and non-hematological toxicity, 11 versus 19% and 18 versus 26%, and a significant increase in the completion of advanced directives, 24 versus 10%. However, with no differences in ER visits, hospitalizations, and average length of stay. This year, 2 additional clinical trials have also been published and reported important and meaningful results for all the adults with specific types of tumors. The GO2 study and the Bridging the Age Gap study also set beautiful examples of how clinical trials should be designed and conducted and can actually expand significantly the evidence base in geriatric oncology. The GO2 study, published by Hall and al. In JAMA Oncology, recruited 559 patients with locally advanced or metastatic gastroesophageal cancer who were treatment naive, for whom the treating clinicians were deeming full dose standard chemotherapy inappropriate due to age or due to frailty. 514 patients for whom chemotherapy was definitely indicated were randomized to 3 different dose levels of capecitabine and oxaliplatin, 100, 80, and 60%, while 45 patients for whom best supportive care alone was considered acceptable were randomized to best supportive care alone versus the same chemotherapy regimen given at 60% of the full dose. For the first cohort, primary endpoints were progression-free survival and overall treatment utility. For the second cohort, primary endpoints were overall survival, patient-reported fatigue, and quality of life. A key innovative feature of the GO2 study is the use of overall treatment utility, which is a composite endpoint taking into consideration both clinicians and patient perspectives to determine the presence or the lack of treatment benefit. As you can see here, from a clinician point of view, this involves considering not only radiological response, but also clinical response and quality of life, while from a patient perspective, this involves taking into account toxicities, interference with daily life, and considering the treatment being worth pursuing. Good OTU implies benefit scored by both clinician and patient. Poor OTU implies lack of benefit scored by both clinicians and patient, and intermediate OTU implies discordance between the two. Patients enrolled in the study at a median age of 76 years in the chemotherapy intensity cohort and were slightly older in the chemotherapy versus supportive care cohort, as expected. 56 to 61% and 69 to 70% of patients were severely frail, respectively in the chemotherapy intensity and the chemotherapy versus best supportive care cohort. Frailty was defined based on genetic assessments, including BMI, presence of weight loss, time to get up and go, falls, cognitive status, activities of daily living, social support, psychological status, fatigue, and polypharmacy. In the chemotherapy intensity cohort, patients receiving 80% or 60% of the full chemotherapy dose had non-inferior progression-free survival compared with those receiving the 100% dose. However, those receiving the 60% dose had lower toxicities and better OTU. In the chemotherapy versus best supportive care cohort, no statistically significant differences in overall survival were observed. This trial showed that reduced intensity chemotherapy can provide a better patient experience without significantly compromising disease control and should be considered for older and/or frail patients. The Bridging Age Gap study was an observational prospective cohort study recruiting 3,416 women aged 70 plus and diagnosed with operable breast cancer in 56 breast units in England and Wales between 2013 and 2018. The study collected data on genetic assessments, breast cancer parameters, treatment outcomes, and quality of life to describe their characteristics, the patterns of treatment and outcomes, including toxicity and quality of life, and to develop a web-based decision tool to aid decision on primary endocrine therapy versus surgery and adjuvant chemotherapy versus no chemotherapy. The study allowed proxy participation to facilitate the recruitment also of patients with cognitive impairment. Here, I will focus only on two study analyses that were published in 2021 on the use and impact of chemotherapy. In these analyses, the investigators defined the risk of breast cancer recurrence based on standard clinical pathological characteristics, including receptor status, grade, nodal involvement, and gene expression profile, and fitness based on performance status, activities of daily living, instrumental activities of daily living, charts on comorbidity index, number of prescription medications taken, nutritional status, and cognitive status. Among 2,811 patients who underwent surgery, only 27.8% of those were fit and had high-risk breast cancer have received chemotherapy. This suggests some degree of potentially undertreatment in this patient population, although fit patients with high-risk breast cancer, we would deem them potentially benefiting from the use of cytotoxic therapy. On the other hand, in those with high-risk breast cancer receiving chemotherapy, the study documented a reduction in the risk of metastatic recurrence, but no impact on overall or breast cancer-specific survival, even after matching patients for disease stage and fitness. Improved survival was seen only in those with ER-negative disease, consistently with prior data from large retrospective analysis from the States. Among 1,520 patients with high-risk disease and undergoing surgery, so those for whom we would consider chemotherapy, the study reassuringly documented only a temporary impact of chemotherapy on quality of life, which is a critical endpoint in the older patient population, with an effect that peaked at 6 months, but that resolved by 18-24 months for most domains of the EORTC-30, BR23, and ELT15 questionnaires. These studies suggest that fitness is a critical consideration to inform decision-making and discussions with older patients with breast cancer. This year, The updated recommendation from the European Society of Breast Cancer Specialists, EUSOMA, and the International Society of Geriatric Oncology, SIOG, have been published on Lancet Oncology and are now available to support decision-making in this population. They suggest that therapeutic decisions should be driven not only by chronological age, but crucially involves the use of genetic assessment and careful consideration of life expectancy, competing risks of mortality, patient preferences in order to minimize the risk of under and over treatment in older patients with breast cancer. In conclusion, similarly to what happened during the last 2 decades, when we have increasingly moved to consider biomarkers to drive anti-cancer treatment decisions, along with more classical aspects such as histology, grade, and stage, I believe we should do the same when considering our patients and overcome the limitation of considering only chronological age and performance status and look at the routine implementation of CGA, comprehensive genetic assessment, to motivate treatment decisions in the context of life expectancy, organ function, comorbidities, functional status, social support, quality of life considerations, and obviously patient preferences. And perhaps also investigate the potential interplay between aging biomarkers and tumor-specific biomarkers to influence outcomes of anti-cancer treatment. This is to me also precision medicine. On a final note, let me highlight a few useful resources if you're interested to learn more about the field of geriatric oncology. Obviously, the website of the International Society of Geriatric Oncology, SIOG, and our Twitter handles. And let me also invite you to attend our annual conference in Geneva in October 2022. The Cancer and Aging Research Group, CARG website and its Twitter handles. The Moffitt Cancer Center Senior Adult Oncology Program website. This is a pioneering center in the field of geriatric oncology with plenty of resources and tools that you can use in your clinic available on the website. The website of the Journal of Geriatric Oncology, which is the official journal of SIOG and the showcase for all the key research in the field. And finally, the hashtags GeriOnc, GeriHim, GeriSurjong, GeriRadong that you can use to interact and network with the social media geriatric oncology community. Thank you very much for your attention, and goodbye for now.
Thank you all for joining us for this day one and a warm invitation. Join us for day 2 of this colloquium, where we will be discussing the year in review in lung cancer and the mass sessions with an amazing faculty. Reminding you that this colloquium video is now available at our YouTube channel and will be available on demand from now on. These will also be available next week through our partners at the European School of Oncology and eCancer and their websites. From all of us at OncoAlert, thank you once again for joining us and look forward to seeing you all tomorrow.